Hey guys, this is Aaron with Ross Training Academy. Today I'm just going to be talking to you guys about how to write an EMS report using the SOAP format. So the acronym SOAP, S-O-A-P, just stands for Subjective, Objective, Assessment, and Plan. And this is just going to be how you're going to write your EMS reports. I do prefer this format currently. I used to use D-Chart or Chart when I first started in EMS. I thought that was easier because it broke everything down a little bit more, and it really just helped me separate all of the information that happens on a call a little bit more. But as I've progressed, I've started using the SOAP format, and this is just what I prefer currently. So starting with the S, or the subjective information, this is just going to be everything that you are told, whether that's on scene, en route, or prior to your arrival. So in this section, you're just going to say a little bit about what you were dispatched to and what it was for. Anything that the patient tells you, this is going to be the section to put that information. Anything that bystanders, family, any healthcare professionals, nursing home staff, police officers, just anybody who can tell you something and who does tell you something, that's where you're going to put that information here in the subjective tab. And just to be clear, this is only going to be pertinent information for the call that you're currently on. So again, just like dispatch notes, how you responded to the call, the patient's chief complaint, and any other complaints that they might have. If there's any witnesses on scene to what might have happened, that's where you're going to put in their information for what they've said. And then you're also going to put in like medical history, medications, allergies, just anything pertinent for that call. And then we have our O, our objective information. This is going to be everything on scene that you yourself or one of your providers, one of your EMS personnel on scene also witnessed or found out or found on the patient or for the patient. Just anything relevant for the scene or for the patient will go into this objective tab within your report. With that being said, everything you don't find is just as important as everything you do find. So you want to do your pertinent negatives, so things that are important that disprove of an ailment or an illness. That is also what you're going to put into your objective portion of your PCR, your patient care report. So some examples of things that you would put in this report. Weather conditions is going to be that first thing. Vehicle damage. This is going to be more for like MVAs. And the weather conditions can also be put into your report for any outdoor trauma, although it's not oftentimes put in for other trauma besides MVAs. You also want to say just a quick assessment of what the scene looked like, what the home looked like. If you find any drug or alcohol paraphernalia on scene, any medication bottles, any medical equipment the patient might use at their home, any like pacemakers or defibrillators that are implanted on the patient, or like a vest type defibrillator. You're also going to put in your head-to-toe assessment of the patient, everything you find and everything you don't find. DCAT BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. That's some stuff that you want to put in there if you do find it, and then you want to say that it's not in there if you don't find it. And then some more examples: work of breathing, the skin color, temperature, and condition, CTC, the patient's alert and orientated status, the ANO status. Are they alert to person, place, time, and event? If they are, you'll put ANO times 4. If they are not, you'll put ANO times whatever they are. And then in your report, just make it clear what they are not ANO to. And then the GCS status, GCS of 3, GCS of 15, that 4, 5, and 6 for the eyes verbal motor. And you would like everybody to have a GCS of 15 for their normal. If they aren't with a GCS of 15, just say what they aren't and why. So continuing on with the examples, so we'll just say here someone's having an asthma exacerbation. You would expect to see the patient with a increased work of breathing in that tripod position. They might be a little bit sweaty, diaphoretic. They might have cyanosis on their ears, on their mouth, on their lips. They might be using accessory muscles or intercostal muscles around their ribs. They might have some tracheal tugging to their neck. And then you would expect to hear wheezing in their lungs when you auscultate their lungs. So for somebody having an asthma attack or an asthma exacerbation, those are going to be things that you will find, you should find. Some pertinent negatives for somebody who complains of having difficulty breathing or having an asthma attack, that's what their chief complaint is. To disprove that or to put in those pertinent negatives, you're going to say how there wasn't any accessory muscle use. There was no cyanosis. They had a normal SpO2 percentage, and then even put that percentage in there. You'll say upon auscultation, there was no wheezing in their lung fields bilaterally or in all lung fields, all lung lobes. They have dry skin. Just kind of paint the picture of what the patient looks like, because that shows that you thoroughly assess the person. And then moving on to A. So for the assessment, this is just going to be where I put the primary or the chief complaint or the life threat for the patient. So the patient might have 8 things that they're complaining of, but what's going to be the most life threatening if it were a severe condition, or if it is a severe condition, that's going to be what I put as their chief complaint in this assessment tab. So basically you assessed your patient in your prior section, and then now you decide, or the patient will tell you what their chief complaint is, and that's what you just put into the assessment portion. And then moving on down to P, or plan, this is going to be everything else that you've done for the patient. So some examples are going to be your vital signs. You obtained vitals on the patient. In my reports, I say that vital signs were obtained multiple times, but I don't actually list out the vital signs in my legal documents, because I know in my PCR system, there is a separate tab to put in all the patient's vitals, so I don't have to repeat them in my narrative. And that's what this is. This is going to be your narrative. So continuing on with your vital signs, you also have your BGL, or your blood glucose level, between that 80 and 120, 70 to 110. If I have somebody with like altered mental status or weakness, I'll even just say their BGL was obtained, a reading of this was found, a reading of 112 was found. Again, just because the BGL will be listed in my PCR in a separate section, I don't have to say it again or repeat it again down here in this plan section, but I decided to do that in my narrative. It just makes me feel better, really. And then at the ALS level, an EKG was obtained. It was shown to be this rhythm. I manually interpreted it, but in my PCR system, there is another tab where I'll put in the EKG. I can even upload it and submit it into my PCR, and then I'll just put in there that I manually read it, because we should never be using the computer read diagnosis. And then you're just going to say any other treatments that were done on scene. So like IVs, splinting, pelvic binder, backboard, C-collar, things like that is also what you're going to put into your plan section. And you want everything to be pretty cohesive. You want it to kind of flow from the start to the end of the call. Try to keep things as in order as possible when you're writing, especially here in this plan section. And I will say up in the S section, the subjective section. And then continuing on, how the patient was moved to the ambulance or to the stretcher. Make sure that you put in that you secured them to the stretcher, used both guardrails, used all your seat belts. And then once you started transporting to the hospital, what transport mode you're going, what hospital you're going to, any additional riders in the ambulance, and their location within the ambulance. So you have a family member sitting up in the captain's chair with their seatbelt on. You have a family member sitting up in the passenger seat of the vehicle with their seatbelt on. Just make sure that's clear. And then if you have a rider from any additional agency, or if it's your agency, but just off of the engine crew or the truck company. And then you're just going to put in any treatments that are done en route to the hospital, the patient's condition en route to the hospital, and any reassessments or changes, or if there's even no changes. You want to make sure that you put that in this section, that you reassessed your person while you were still transporting, and they remained this way or they changed to this way, whether it's positive or negative. And then once you're at the hospital, where did you take the patient to? Did you take them up to the waiting room? Did you take them to an ER room? Did you take them to CT? Did you take them to the OB section of the hospital? And then how was the patient moved from your stretcher to the hospital bed or the hospital chair? Did they need assistance? Were they able to stand and pivot? Were they able to self-ambulate from the ambulance to the waiting room? Just how did they move from the ambulance to wherever they ended up before you handed off care? And then just make sure you put something in there that you did give a verbal report and transferred care to someone of an equal or higher level of care within the hospital, just so that everybody knows that you didn't just abandon this patient somewhere within the hospital. And then I always put in that I'm clear and back in service, and then I'll just sign off my report, use my name, and then my title. So that's how you write in the SOAP format. We're going to scroll down and I'll show you guys kind of an example of how this would look like. This is not going to be a real call, just wanted to throw that out there. So I'll just go ahead and start reading it to you guys. Medic 6, Engine 6, and PD were dispatched emergent for a 64-year-old male involved in a single vehicle MVA. PD state the patient is awake and talking and drove off the road due to falling asleep while driving. Engine 6 state the vehicle is secure and safe to maneuver around. The patient states they've only slept 8 hours in the last 2 days due to work-related stress and was driving to church when they fell asleep. Patient states they remember driving through a green light, then waking up after driving into the ditch. The patient states the last speed they remember driving was 20 miles an hour. The patient states they woke up as they were driving through the ditch and before they hit the fence. The patient states, I don't need you all here to help me, but I'll let you since you're here. So I want to just pause right there. This little piece, the patient states, I don't need you all here. I do have that in quotes, whereas like other things that the patient states is not in quotes. So the reason I did that is because, so like up here, the patient states they've only slept 8 hours in the last 2 days due to work-related stress. That might not have been exactly what he said word for word, and so I don't use quotes there, but it is what he said or what I perceived he was trying to illustrate, and so I make sure that I say that the patient states this, but I don't quote it. So something here in quotes, I don't need you all here to help me, but I'll let you since you're here. This is put in quotes because it is something that's more of a big deal. It is something that would stand out on a call. It sounds like they don't want you, and people have every right to refuse. Doesn't matter how messed up they are, as long as they're ANO4, GCS 15, orientated in speech, able to follow commands, all that good stuff, they can refuse. So the reason I put this in quotes is so that this person wouldn't be able to come back and say that I forced him to go to the hospital. I didn't kidnap him, because I remember him saying word for word this sentence here, because that is a pretty significant sentence to say. And then with combative patients, just continuing on with this, with combative patients, if this was a combative patient, I would also use quotes. You know, if they're cussing at me, yelling at me, I would quote exactly what they say just to help show or paint that picture of how the patient was presented upon my care. So significant, memorable statements, I do put in quotes. Anything else, I don't really use quotes for. That's just what I personally do. I've been to court a couple times, and there hasn't been any backlash from this, and there hasn't been any backlash from my QA personnel. So continuing. The patient complains of generalized headache, dizziness, mild neck pain at a 4 out of 10. That's worse upon movement. The patient denies any other complaint. The patient states they had their seatbelt on, they don't think they hit their head, and they had no LOC, loss of consciousness, during or after the accident. The patient states a history of a stroke 4 months ago, an AFib, and takes Eliquis. The patient states no known drug allergies. The patient denies deficits from their prior stroke. The patient states there is no other vehicle occupants. The patient denied analgesic medication for their pain. So when I'm writing my narratives, I don't really list out the medications or the medical history, because I know in my PCR there's another tab where I fill out all of that. But something trauma related, something that's pertinent, is Eliquis, a blood thinner, and so I make sure I put that in this section here, the subjective, just to show that I did thoroughly assess my patient, I did thoroughly talk to them, and this is what I found. It really just makes me feel better. So that's your S. Now, moving on to the O. The patient was found sitting in the driver's seat of the vehicle, their vehicle that was in park. There were no other obvious vehicle occupants. The vehicle was a single cab pickup truck with multiple airbag deployment, moderate vehicle damage with roughly 6 inches of vehicle intrusion to the passenger side door panel into the patient compartment or passenger compartment. The weather appeared warm, clear, and sunny. The roads appeared to be dry and non-slick. The patient was found to be ANO4 with a GCS of 15 and was oriented in speech and able to follow commands, but did appear slightly delayed in response. The patient had a minor abrasion to their right hand palm, and hemorrhaging was self-controlled with minimal dry blood on the patient's palm. The patient had no other obvious DCAT BTLS noted to their head, face, neck, back, chest, abdomen, upper extremities, lower extremities. The patient's pupils were pearl at a 3. The patient had no obvious nystagmus. The patient had no obvious facial droop or slurred speech. The patient had CMS intact times 4, meaning in all 4 extremities. The patient had strong and equal extremity movement times 4 in all 4 extremities. The patient was breathing at a normal rate and depth with no obvious wheezing or stridor upon auscultation. The patient's skin was pink, warm, and dry. The patient had a minor grimace upon movement. The patient grimaced when their posterior midline neck was palpated, but no abnormalities were found to the area. The patient had no obvious oral trauma and was not incontinent. So that's the O section. That's everything that I found for my person. Moving on to the assessment, or that A, or that chief complaint, the patient's CC, chief complaint, is middle neck pain, rated at a 4 out of 10. And I'm sorry, that says midline, not middle. So, moving on to this P section, the last section, that plan section, everything that was done for the patient. I arrived on scene, talked to the patient a little bit, and now I started doing things for him. So, EMS placed the patient into a C-collar. The patient tolerated the collar, meaning that they didn't pull it off or take it off or move their neck around, their head around. EMS obtained a set of patient's vitals, which are as follows. The patient was then able to stand from the driver's seat of their vehicle and pivot to sit on the stretcher. EMS then secured the patient using all stretcher straps and both guardrails and moved the patient into the ambulance. Once in the ambulance, EMS obtained a BGL, which read 126, a 12-lead EKG, which showed a sinus rhythm, which was continued en route to the hospital with no obvious changes or abnormalities. EMS obtained an 18-gauge IV in the patient's left AC using an aseptic technique. EMS then began transport non-emergent to your local trauma ER with one firefighter rider in the patient compartment. En route, EMS obtained another set of patient vitals, which are as follows. En route, the patient remained ANO times 4 with a GCS of 15 and was now oriented in speech and able to follow commands with no delay. The patient states they now only have 4 out of 10 midline posterior neck pain. The patient denies any other complaints. The patient's skin remained pink, warm, and dry. Once at the hospital, EMS brought the patient to the ER room they'd be staying in, where the patient was transferred from the stretcher to the hospital bed via the draw sheet method. So just drag them on the sheet that they're laying on to the hospital bed. EMS then gave a verbal report to hospital staff and transferred patient care to RN Johnny Doe. EMS then cleared the scene and went back into service. And then that finishes up our P, our SOAP. And then down here at the bottom, I always say all times are an estimate for my reports, just because in my PCRs there are like time sections and there are medications that are at like time intervals, and just like dispatch time, en route time, on scene times. I always just say all times are an estimate just because there are mess ups that happen, unfortunately. It's really hard to keep track of times exactly, and so they're all estimate. They can be seconds off or they can be a minute or two off. Whether that's dispatch's fault, whether that's EMS's fault, it's just something that happens. So I always say all times are an estimate just in case things don't add up exactly, because when you're in the moment, things do add up pretty exact. You keep better track of things, but when that all has to be transferred to your PCR, sometimes things change. Something as little as your monitor, your cardiac monitor, being off by a few seconds or being off by a couple minutes. When you upload everything to the cloud and then to your PCR, that time difference will be reflected in your PCR, and then that'll throw off your times as well. And so just to help cover myself and to help explain all of what I just said, I just put in all times are an estimate. And then I just sign it with my name and then my title, and then just not based on a real call. that's just for this. But yeah, that is basically it. That's how you write a report using the SOAP format. Hopefully this helps you guys out a little bit. Hope you guys enjoyed. Please feel free to like, comment, and share. But that's it for this video. See ya.